Okay, it's about time, so we start in just a few moments. Okay, so anyone, is the is the sound okay? Can you all everybody hear me?
Yes, doctor.
All right. So it's already 9 a.m. So we're going to start today's lecture on the pathology part of pulmonary tuberculosis. Okay. Sorry. Okay. So in this lecture, I will explain or I'll be talking on the pathology part of pulmonary tuberculosis. And for the rest of the week, most probably you will have another lecture on the uh, drugs or the medication that are used for pulmonary tuberculosis and including the microbiology part of the pulmonary tuberculosis. But for my part, I'll be talking regarding the pathology part and a little bit on the clinical aspect of the pulmonary tuberculosis. Okay, for the learning outcome, as usual, you can find out the learning outcome from the guidebook that have been given to you. All right. So we start with a scenario. So just um, to stimulate our thinking process regarding throughout the lectures. So I will give you a scenario for this case, for this lecture. So a 32-year-old man, known case of a HIV positive, presented with prolonged non-productive cough for the past 2 months. And the condition is associated with constitutional symptoms and fever with night sweat. So if you see words of mentioning constitutional symptoms, so that means the patients or the person is having loss of weight and also loss of appetites uh, during the symptoms. So this is what you should know. And he had a fever and with night sweat. And previously, he had a roommate who had been diagnosed with pulmonary tuberculosis around 4 years ago and had completed his treatment, the roommates. And on chest radiograph was performed and it shows an area of cavitations at the upper lobe of his right lung. So to view the chest x-ray, so here is the cavitation, sorry. Okay, here is the cavitation. You can see uh, this side is the normal lung. And this side is where the cavitation is. All right. And when two tests were performed and it is positive, sputum smear shows the presence of acids fast bacilli, ESR is raised, and CD4 T cell counts is low. So all of these are the investigation that are related to this patient. And he was then started with anti-TB treatment, which is the isoniazid, rifampicin, pyrazinamide, ethambutol, and also streptomycin. Right? So this is how the scenario that you might encounter during your practice afterwards when you see a case of TB, and including this scenario, I already given to you the risk factor to uh, for contracted for person to contract TB. All right, on to our lecture. So for the etiology, mainly the pulmonary tuberculosis is caused by a bacteria, which is the bacilli type of bacteria, and it is named. The name is Mycobacterium tuberculosis. And usually, if you do a Ziel-Nielsen staining, you can see that this bacteria able to stand the acid wash during the staining process. So that is why the name is acid fast bacilli. So it able to withstand the acid wash during the staining process of the Ziel-Nielsen. Okay, clinically, when to suspect that this patient or this person having TB. So number one is the presence of chronic cough. Usually we take chronic if the cough occur for more than 2 weeks. And next is the constitutional symptom. As I mentioned previously, there is a loss of weight and also appetite. If the patient presented with hemoptysis, sometimes the disease is called dry cough ataupun batuk kering, but sometimes it does has some production of sputum, and sometimes the sputum is also stained with blood. So this is what we call hemoptysis, which is the blood stained sputum. Right. Next, patient could be presented with on and off fever, and the most important thing is the night sweat. And apart from that, for the risk factor, maybe you can ask the patient or the person if there is an immunocompromised patient or person, for example, in HIV. And as you know, that pulmonary tuberculosis is an AIDS-defining disease. It means that a person with HIV still does not consider to become AIDS until he or she get been affected by some of the disease that we call as AIDS-defining disease, and one of it is the pulmonary tuberculosis. So if a patient or a person who has HIV and being affected or infected by pulmonary tuberculosis, so this patient is considered to be in AIDS stage. So meaning he already manifests the AIDS in his process. And sorry, before I'm going further, apart from HIV, other immunocompromised diseases or condition can cause also pulmonary tuberculosis. For example, in a patient with diabetes mellitus, where the immune system of the body is weakened by the disease, by the presence of a high amount of glucose. So that is why in patient with diabetes mellitus, the immune system is a bit immunocompromised. So he or she is prone to develop or to get pulmonary tuberculosis. And apart from that, other, for example, in chronic disease, for example, in cancer patient, also the immune system is not that good. So he or she is prone to develop or prone to contracted tuberculosis in his life. Okay, I will go on to the pathophysiology of the symptoms for pulmonary tuberculosis first, and then we will go in a bit detail on the pathogenesis of pulmonary tuberculosis. So currently, this is the pathophysiology. Okay, pathophysiology is what the disease cause or disease change, how does the disease affected the physiological processes of the human during the infections. Okay, for number one is that the most important thing is the night sweats, the presence of night sweat in PTB patient. So in PTB patient, there's a lot of cytokines being released by the inflammatory cells, by the white blood cells and everything. So these cytokines, especially interleukin-1, will cause that patient to develop fever. Okay, but okay, in a normal human being, the production of cortisol or the steroid hormones in a normal human without any disease, usually we can see there's a diurnal variations. Means in the morning the cortisol level is very high, and during nighttime the cortisol level is a little bit lower compared to the daytime. But in the pulmonary tuberculosis patients, the cortisol has some derangement, and the diurnal variation is a bit different compared to the normal person, in which in pulmonary tuberculosis patients, the cortisol is high at night. So this is why that the patient develop night sweat during nighttime. This is because the cortisol will have an effect of antipyretic kind of effects. So this antipyretic will cause the patient to temperature to become lower and to make the patient sweat a lot during nighttime. So that's why there's a night sweat in a pulmonary tuberculosis patient, as I explained down here. You can read afterwards. All right. So apart from that, we need to understand the TB complication first before we go into the pathology part of the pulmonary tuberculosis. So for the most common complications that can occur for this patient is, as I mentioned in these slides, this patient can develop hemoptysis, pleurisy, pleural effusions, empyema, pneumothorax, aspergilloma, laryngitis, cor pulmonale, enteritis, and so miliary tuberculosis. These are the most common complications for a person with pulmonary tuberculosis to have. Okay, number one, this is again the pathophysiology. So again, you really explain how does TB causing hemoptysis. So when there is infections, so meaning in this case the PTB, there will be some inflammations. So when there is inflammation, as you know, as you learn in the first, I think the first block, regarding the inflammation, there will be some increase in the blood vessel dilation and increase in the blood circulation at the inflamed site. So when there is inflammations, there will be hyperemia, and because of the dilation, the enlarged blood vessels during the inflammations, it will cause rupture of small vessels, and this rupture of small vessel can extravasated the bloods into the alveolar spaces, and then this blood irritates the alveolar spaces and cause the patient to cough out blood. So this is how hemoptysis occur. So the production or the effect of coughing out blood or blood-stained sputum is what we call hemoptysis. Right? Next is the pleurisy and pleural effusion. So pleurisy means pain during breathing, coughing, or movement of thoracic cage. So any kind of movement or activity of the thoracic cage can cause pain when there is a pleurisy. So how does this happen? So when there is a TB infection, this TB infection can spread to the pleura, means from the lungs itself, and it spread to the pleura, and this will cause some inflammation of the pleura. And when there is inflammation, there's a lot of inflammatory cells there. The rubbing process between the inner visceral pleura and also parietal pleura can cause pain during movement or during breathing or during coughing. And this also, because there's inflammation there, it also causes the production of effusion there. So that is why in TB sometimes we can see there's some pleural effusions in the X-ray or during the auscultation of the lungs or thoracic cavity area. Next is the empyema. Empyema, as I mentioned before, empyema is a pus collection inside the pleural cavity. How does this happen? Again, it's almost the same with pleurisy, but in pleurisy, it's just the inflammation that occur there. But in empyema, sometimes the Mycobacterium tuberculosis or the bacteria can spread to the pleural cavity and stimulate the inflammatory cells aggregation or accumulations there and causing it to form empyema. So empyema again is a pus in the pleural cavity. All right. Next is pneumothorax. Again, pneumothorax, because PTB infection occur in the lungs, in which there's a airway, air is coming in and out of the lungs and also the large airway, and sometimes this can cause rupture of the airways. So when there is a rupture of the airways, so air from the outside during breathing can seep into the pleural cavity and cause pneumothorax. So this is another complications of pulmonary tuberculosis. So this occur also caused by the inflammation and destruction of tissue caused by the Mycobacterium tuberculosis infections. Next is the aspergilloma. So aspergilloma is actually a type of fungal infection. It is caused by the Aspergillus species, and it is usually seen as a fungal ball. So when there is a pulmonary tuberculosis infections, and there will be a process that we call pathological process that we call caseating necrosis. So when there is a caseating necrosis, so it will leave with a cavitation inside the lung. So this cavitation is a good place for the aspergillus to grow in. So aspergillus sometimes we can find in our surrounding, but due to the very competent, very good immune response, it does not grow in our airways. But in a patient with cavitation due to pulmonary tuberculosis, so there will be lacking of inflammatory cells that can protect this cavitation, so the aspergillus will enter the airway and sits at the cavitation and grow there. So when it grows, it tends to turn into a ball, like in this case. So it's actually already there is a cavitation here, and the whitish one here is the aspergillus, groups of aspergillus fungi. All right. Okay. Next is the TB laryngitis. This is another complications that can occur in pulmonary tuberculosis. So when there's a pulmonary tuberculosis infection, the TB is spread through the airways, means from the lungs, it's spread outwards into the airways and seeded in the larynx. So sometimes it's seeded in the larynx and cause TB laryngitis there. So this is another complications of TB, of the pulmonary tuberculosis infections. And the next one is the core pulmonale, where it usually occur in a patient who had already healed by the from the pulmonary tuberculosis. Okay, you can see it when there is a pulmonary tuberculosis infection and already healed, it will leave because of the inflammatory process of the pulmonary tuberculosis infections. So it will heal by a second degree type of healing. So it will leave with a lung scar or lung fibrosis. So this lung scar or lung fibrosis will increase the pressure in the lung arteries and thus cause hypertrophy of the right ventricle due to because of the heart needs to overcome the pressure, the increased pressure in the lung arteries to make sure that the blood flows into the arteries. So that is why the right heart or right ventricles of the heart become hypertrophic in the process. Next is the TB enteritis, another complication. Again, we start with PTB infections. Because of sometimes these pulmonary tuberculosis patients do cough out some amount of sputum, and if this kind of there's a lot of amount of sputum being swallowed, so the TB will be ingested that are contained within the sputum will be ingested by the GIT macrophages and cause TB enteritis later. All right, for the risk factor of the pulmonary tuberculosis. Number one is the close contact. So number one, you need to know that in order for a person to contract pulmonary tuberculosis, he or she need to have a close contact with a known PTB patients. So this depends on the how long does the hours or how long does the contact occur. There's some guidelines say you need to be in contact for more than 8 hours a day to contract TB, but sometimes we can see in some patients who has a lesser amount of contact time do develop pulmonary tuberculosis in their life. And apart from that, you need to understand also the close encounters, because as in, TB is a disease that can spread by aerosol, infected aerosolized materials or sputum. So you need to have a close encounter because aerosol can travel up to 4 to 6 meters. So if you are within that range, so you are at risk to contracted tuberculosis. And apart from that, you need also to see either it is a household or non-household contact. So household means stay together in house, or the person who, for example, going to class together or going to work together in the same office. So you need to see also that kind of balance. So these are the risk factor for if you have or the person have a close contact with PTB patient. Next is, as I mentioned previously, immunocompromised individuals, for example, in diabetes mellitus, or in the scenario that are given earlier, HIV patients, or sometimes patients who had already lungs pathology, for example, chronic obstructive pulmonary diseases, patient with end-stage renal failure, malignancy, malnutrition, and also who use immunosuppressant drug, for example, in a SLE patient. So all of these kind of conditions will cause the immune system to become compromised and a bit lower and unable to fight infection effectively, and thus put them at risk to develop pulmonary tuberculosis. Next is the substance abuser and also cigarette smoking, for example, drug user, for either intravenous illicit drugs, or sometimes who use cocaine, who sniff drugs into their airway, into their nose, and sometimes patient with excessive alcohol consumption, and also current smoker. These are the things that a person do that can put them at risk to develop pulmonary to being infected by mycobacterium tuberculosis, and thus proceed with pulmonary tuberculosis. So all of this will cause local kind of immunocompromise to this patient. So there will be lack or incompetent immune system if they proceed to use this substance, and also being continuing smoking cigarettes in their lifetime. Next, people living in an overcrowded condition, for example, homelessness, history of incarceration, institutionalization, and also prisons. So remember, it's not that only in crowded places who are in these categories that I mentioned here. Sometimes you can see also cases of pulmonary tuberculosis occur in hostels, in educational center, for example, in school, boarding schools, or sometimes in universities where the students live together. Sometimes you can see there's a cluster, or there's groups of students who have been contracted to pulmonary tuberculosis. This is due to the overcrowding that can occur in the hostels or in the places like this. All right, so we on to our the essence of this lecture, which is the pathogenesis of pulmonary tuberculosis. So in this part, I will try to explain, I will try to help you to understand and to be able to explain regarding the pathogenesis of pulmonary tuberculosis. All right, so when I say pathogenesis, it will start with infection or the etiological agent, and it will end up with the infection, the pathology itself. So in this case, the etiological agent is the mycobacterium. Okay, the etiological agent is the mycobacterium tuberculosis, and the pathology is the pulmonary TB. So this is how you explain pathogenesis. So bear in mind, any kind of pathogenesis, not only particularly in the pulmonary tuberculosis, in any kind of pathology, in any kind of disease, when you are asked to explain regarding the pathogenesis, So you start with the etiological agent and you go on the process and end up with the pathology or the disease that you are being asked. So these are another tips to answer pathology questions. Okay, so we on to our pathogenesis of pulmonary tuberculosis. So we start with the infected person. Yes, of course. Why you ask? I think you will wonder why they start with infected person. Yeah, because the initial stage or the reservoir of the pulmonary tuberculosis is the living human. So it can survive on the surface or of a floor or table or anything, which is unliving objects. So the bacteria cannot live on that kind of surface. So it need a reservoir. So the reservoir for the Mycobacterium tuberculosis is the infected person. So this is how it starts. So this infected person will have symptoms of coughing, sneezing, coughing, causing the infected aerosolize to become to come out from his or her airway. So the infected aerosolized sputum, which contain a lot of Mycobacterium tuberculosis, being inhaled by a healthy but at risk individuals in this part. So all of these Mycobacterium who had been inhaled will be then transferred to the large airway and it will stuck into the lung parenchyma. Next, this Mycobacterium will be engulfed by alveolar macrophages. So all of these alveolar macrophages will engulf all of the Mycobacterium tuberculosis here. So it will, because there is the antigen protein that it can find, which is the spike one here, which can be detected by the receptor in the of the macrophages. So it will be engulfed by these macrophages to try to destroy all of the these bacteria. So this process is called phagocytosis. Next, all of these engulfed mycobacterium will be put is tried to be destroyed by the macrophages here. So there will be it will be put in these vacuoles within the cytoplasm of the macrophages, and this will macrophages will cause try to arrest the maturation of the bacteria and cause lack of acid pH. Sorry. Right. And these macrophages will try to destroy all of the mycobacterium, but this mycobacterium has the ability to uh, to protect themselves against these insults. So what they do is they put themselves into the maturation arrest, causing like a coating of lack of acid pH, and this will cause ineffective phagolysosome formations within the cytoplasm. And this will cause the proliferation of the mycobacterium in the macrophages. So you can see some of the mycobacterium will be increased in numbers, even inside the vacuoles of the macrophages. But some of these mycobacterium can be destroyed by the enzyme that can be found in the cytoplasm of the macrophages. And this destroyed mycobacterium is then processed and presented to T cells here. So all of the spike protein that I mentioned previously is then being pushed outwards and being presented to the T cells, and macrophages also will release interleukin 12, which then stimulate T cells to transform into T helper cells, in which this T helper will help re-stimulate again the macrophages by the release of interferon gamma, and then it will activate macrophages to cause them to become activated. So activated macrophages will then release other enzymes that can destroy the mycobacterium. For example, in the phycolysosome maturation and activations, production of nitrite oxide, production of reactive oxygen species, and autophagy of the mycobacterium itself. So all of these things will cause the mycobacterium to being destroyed and and kill the mycobacterium. But unfortunately, this mycobacterium is bacteria is able still some of them are able to survive all of these enzymes and live inside the cytoplasm of the macrophages. And this activated macrophages is then release tumor necrotic factors, or TNF, and also chemokines, and this will stimulate the monocytes to come and circling these infected macrophages, and try to cause them to become necrotic or die, and try to reduce the oxygen supply to the center, to the mycobacterium, so that it will help the in a process of killing the mycobacterium or the bacteria, to kill them. So this process, in which the monocyte from the circulating monocyte become epithelioid cells or activated macrophages, and also other sensitized T cells accumulated around it, and this is what we call epithelioid granuloma. So all of this will encase the infected macrophages at the center there, and causing these macrophages to become necrotic and die, and hopefully along with the mycobacterium within them. So this is why the body tries to develop epithelioid granuloma. Next, so that is the process of the primary infections of Mycobacterium tuberculosis and the formations of the epithelioid granuloma or caseating granuloma in primary or secondary pulmonary tuberculosis. So, and next we need to understand what happens after initial infections of the pulmonary tuberculosis. Okay, it starts with the primary tuberculosis. So at the center here is the primary tuberculosis. So what happened after a person is already being infected by the pulmonary tuberculosis in the first place? So there will be a immune response or immune process that I mentioned previously. There will be caseating in the affected lung parenchyma and also perihalar lymph node. So there will be there will be caseation or granuloma formation here and also here. And this is because these two area is where the bacteria is. So it will cause caseation, or it will cause formation of granuloma there. So in some patients who had been infected primarily by primary tuberculosis, they can heal, 100% heal. Nothing will be seen in this patient or person. No more mycobacterium live inside him or her. So this healing process will cause there's a formation of scar at the affected area, like in the primary part. But in other unfortunate person or patients, he or she can develop latent phase TB. So as I mentioned, TB can survive inside the cytoplasm, the macrophages. So they can survive there and stay dormant for the rest of their life, or until secondary TB occur. So there will be in this unfortunate person, we call it the latent phase TB. So this is the second pathway that a primary TB can go. So it can turn into a latent phase TB, and then proceed with secondary TB, or just lay and just be a latent phase TB for the rest of his life or her life. Next is the most unfortunate person. He or she can develop progressive primary TB. So two from these two lesion just at the lung, within the lung, and also lung parenchyma and also perihilar lymph nodes, the TB can spread as well or can become worsened in this patient. So we will see this progressive primary TB first. So what can happen in this patient? The TB will become progressive, so it become worsen. So the patient or the lesion at the lung will become larger, or it will increase the number of the lung. And sometimes this mycobacterium can go into cause hematogenous spread and cause miliary tuberculosis. So miliary tuberculosis can be seen in the liver, in the kidneys, and also in the spleen. So this is the example on how does miliary TB looks like, and I will explain regarding the pathological features later. Next is the secondary TB. So remember that this part here, in patient who had been having a latent phase TB. So after latent phase TB, where in which this part here, so it can be reactivated. So how does it become reactivated? Is when there is a immunosuppression. So this is where in which the body immune system become weakened and the mycobacterium will be revived again and become strong again, and causing a lot of damages into the lungs and also in this patient. Or it can be the patient is already being healed completely from pulmonary tuberculosis, but already it then being reinfected by another strain or another type of sometimes the same type of pulmonary tuberculosis, and become reinfected again, and this is what we call secondary tuberculosis. So in this case, there can be two consequences. Either number one, it can go up here and cause localized caseating disruptive lesions. So it just localized within the lung, and it cause destruction in the lung parenchyma, destruction of the lung tissue, and sometimes just adjacent tissue. Or it can progress into progressive secondary TB, in which it is almost the same with progressive primary TB, where it can cause local destruction of the lung parenchyma, and also it can spread hematogenously to cause the miliary tuberculosis in the liver, again in the kidney, or inside the spleen. So in this where there is a lot of capillary channels where the mycobacterium within the macrophages or within the monocyte can become blocked and become stuck here and causing a lot of damages to these organs. All right. So next is the morphology parts of the pulmonary tuberculosis. So for the primary tuberculosis, grossly, as I mentioned, you can see two things. Number one is the lesion within the lung parenchyma over here. Number one is the lesion within lung parenchyma, and number two is the lesion within the perihilar lymph nodes. So these two things is what we call gone complex. So meaning complex means there are two things or more than two things inside a complex. All right. So the lesion within the lung parenchyma is usually what we call gone focus. So remember, within the lung parenchyma is gone focus. Whereas the lesion in the lymph nodes is we just name it as perihilar lymph nodes. So these two things is what considered to be gone complex. So all these things add up to be gone complex. So remember, in primary TB, you will find gone complex within the lungs. This is another samples of the gone complex. All right. This is another sample of gone complex. I will help you orientate. The blue one, the yellow one is the normal structure. Just help you to orientate. So this is the This is the trachea coming out from here, and it's spread into this carina into right and so left lung. So this lung already been cut open. All right, these are the lungs, and you can see there's a whitish lesion at the center here. So I'll be using red color here. So this is one lesion here, there's another lesion here, here, and also here. So all of this whitish lesion is actually the lymph nodes. And this one here, the periphery one, is the gone focus, in which the lesion within the lung parenchyma. And here, this one and this one, and few of these are the peripheral lymph nodes. There are lots of lymph nodes being affected by the tuberculosis. This again, gone focus, just to to help you. Why does sometimes we call it caseating, caseating necrosis? So why does it call caseating? Because it cheese-like, yeah, cheese-like. It does not resemble anything cheese-like in pizza. The one stringy kind of cheese, but it is more like this kind of cheese, the crumbly type of cheese. So this how caseating lesion looks like. This caseating lesion usually we found in the gone focus, especially here. Oh, sorry, not that clear. Here, this is one gone focus have been just bisected into two. So this is the gone focus. So you can see there's the texture of the lesion inside here is almost similar with the cheese right here. So it's a bit crumbly kind of a texture. So that's why we call it caseating lesions. All right, for the secondary tuberculosis, usually the lesion is almost the same with the primary tuberculosis, but to some extent it appears to be more aggressive, more destructive kind of lesions. And if it is presented with a miliary kind of TB, for example, in this picture here, in the liver, so you can see there's a multiple whitish spot that can be seen. So, okay, I will help you orientate. You can see this red spot here. Don't worry about it. It is a normal liver parenchyma, but what you need to worry is the whitish spot here, here, and everything here. So all of this whitish spot here is actually the granuloma or the where the mycobacterium sits in the liver. So you can see there it will stimulate immune response and causing granuloma formation. And grossly, you can see it is a bit whitish in color. Next is in the kidney. This is one massive one. You can see there's a whitish area in the renal parenchyma. So this is the normal kidney, and this is the other one is the affected kidney. So if you compare kidney over here, you can still see some renal parenchyma here. But in this case, in this affected kidney, you just see the whitish kind of a lesion here. So this whitish kind of lesion is only is what we can see if the kidney is being affected by pulmonary tuberculosis. This one, a massive one, maybe quite sometimes that this patient having problems, but usually he failed to come to seek treatment, and this caused what this whitish lesion over here. So this is how miliary TB in the kidney looks like. This is the massive part, massive kind of example. Next is the spleen. Again, I will help you orientate. Okay, you can see this one, the brown color one. Don't worry about it. This is just normal. The one you should worry is this whitish spot that occur here, here, and also here. So all of this whitish spot is actually where the mycobacterium sits in the liver, spleen parenchyma, and causing um, granuloma and immune response at the within the spleen parenchyma and causing these whitish spots here. So this is how the miliary TB in the spleen looks like. All right. The next one is the histopathology of the pulmonary tuberculosis. So you might be wondering, how does a granuloma looks like under microscope? So this is how it looks like. So as the name implies, grossly you can see caseating lesions. So caseating means there's some degree of necrosis there. So when there's some degree of necrosis, you should see necrosis also in the histology. But how does it look like? So it looks like in this picture. So at the center here is the necrotic part. What you can see is just a pinkish acellular kind of material. So you don't see any cells or any nucleus within at the center here. So it's just a necrotic debris, pinkish materials, granulated pinkish substances at the center. So all of these are the necrosis. So surrounding these necrotic debris is actually the histiocytes. You can see there's this one, sorry, all of these cells, all of this part here is the histiocyte or the epithelioid cells. Sometimes you can see clearly, but sometimes it just seem to have like a large cells with a large nucleus. So all of these are the epithelioid cells. And the outermost part, there will be some sprinkle or some groups or aggregation of lymphocytes at the outermost part of the lesions. So granuloma, you remember, if you are trying to describe granuloma, there are three layers. At the center part is the necrotic part. Outer, in case this necrotic part is the epithelioid cells, and the outermost is the lymphocytes. So remember, you need to include all of these three characteristic features to mention to conclude that the histological fields or the histological pictures or slides that you receive is the um, the granuloma formations. This again under low power you can see almost similar features. All right. At the center here again is the necrosis, necrotic debris. Surrounding it is the epithelioid cells, and the outermost here is the lymphocyte. And in this field, you can see some of these epithelioid cells fuse together and form what we call a multinucleated giant cells. So this is one nice multinucleated giant cells. You can see this is actually one cell. You can see all of this bluish thing inside them. Inside it is the nucleus. So it's actually a fused together epithelioid or macrophages that causing that form into a multinucleated giant cells. And this again just some highlight just to help you to revise back the histopathological features of a caseating granulomas. How does it looks like? But this one is not from the lung; it's actually from the lymph nodes of a patient who had been contracted with TB lymphadenitis. So it's almost the same. The findings is almost consistent in any kind of lesions in any kind of organs. All right, this is another point you can read afterwards. All right, by that, thank you, and I will post the recording for this lecture afterwards. Any questions that you'd like to ask? All right, so since there is no more questions, wait, I will have a look at chat first. Okay, nothing. People keep already being going to leave the conversation. All right. By that, I say thank you for your time and have a nice day. Again, if you have any questions, you can ask me on the. You can text me or you can send me a message or email. Okay. Thank you. Have a nice day.
Thank you, Doctor.
Thank you, Doctor.